Get started. My name is Marc Kowalsky. Some of you may already know me. I'm one of the shoulder and elbow and sports medicine surgeons at ONS, and happy to be participating in one of our new programs online, which is Ask an Ortho. It's really an opportunity to have a less structured conversation with one of us and ask us any general questions you might have about orthopedics, about your own injuries that you may not have had a chance to ask the doc, or perhaps you just haven't been to the doctor at all, but you've had some of these questions. So there's a couple different ways to ask questions. I think maybe we'll start by adding questions to the Q&A section of the Zoom meeting, and I'll look out for those questions and read them to the rest of the audience. So obviously, feel free to divulge as much or as little as you want about your own health history, but I'm happy to keep it general and try to give information that's as widely applicable as possible. While we're waiting, I just want to take a minute to thank Cindy Catterson. She's our Director of Communications and just puts in a tremendous amount of work to get programs like this up and running. And it's more technologically demanding than it's ever been. And so thank you to Cindy for making all of this happen and making our practice as accessible as possible to our patients and our community. Okay, with all that said, why don't we get to our first question of the evening. What adjustments should patients that are 65 and older make when rehabbing after an injury? Adjustments in areas like frequency of exercise, ratio of exercise to rest, amount of weight and resistance band strength, and other rehabilitation issues. This is a great question. I think it can be answered in a lot of different ways. And of course, there's always going to be the caveat that it's going to depend on what type of injury you have, whether you've had surgery or not. And most importantly, what condition were you in coming into the injury? That's probably going to be the most important determining factor about what type of rehab program you pursue afterwards. But I guess the same rule applies to rehab as it does to prescribing medicine in our practice, which is start low and go slow. One of the most common mistakes that patients can make when they re-enter exercise after recovering from an injury is kind of plowing in too fast. And as you might imagine, that's a recipe for disaster and a recipe for yet another injury. So start low and go slow. And I like to create milestones and benchmarks for patients so that they know when to advance to the next phase. And I usually break it up into 1 or 2 week chunks. And the first week should really just be a dabble. It should just be getting the blood flowing and making sure that you can get the blood flowing without pain. Absence of pain is the first milestone. And then I'll progress week by week or in 2 week chunks with level of intensity, making sure that they can complete each milestone without pain before they advance to the next milestone. I would start every other day when you first get started. That way you build in a day of rest after each episode of exercise. I would also modulate intensity significantly. So the first episode of exercise should be incredibly low intensity, again, just to make sure that your previous pain has resolved. In terms of weight training and resistance training, again, it should start with the absolute minimum. No more than body weight to begin with, and only after you finish, again, a 2 week module of body weight exercise should you then advance to TheraBands. And when you advance to TheraBands, it should be the least intensity TheraBand, the least resistance TheraBand that you have access to, and then on to 2 pound weights, and then on to 5 pound weights. What I often tell my older patients when they are re-entering exercise after an injury is sometimes the injury or the surgery is an opportunity to recalibrate your goals and recalibrate our expectations. In many cases, we're simply trying to do more because we can do more. and we keep increasing level of intensity, we keep increasing weight resistance without clear goals in mind. And our days of training for power and our days of training for competition are oftentimes behind us. And our goals should shift to more health and conditioning, which often means that we may not need anything more than body weight. We may not need anything more than light resistance therabands to accomplish our goals. So I think going low and slow and having clear goals in mind and clear expectations in mind and making sure that we complete each step before we advance to the next step. I think with those 3 parameters in mind, you can hopefully navigate your post-injury exercise safely. Okay, let's move on to the next question. Very sore between my groin and right knee on my right lower extremity. What causes that if I've had it for 2 weeks, set off by a cramp there? I am in good health, older than the age of 80. Okay, so I'm going to summarize. What could be causing 2 weeks of pain radiating from your groin toward the knee in an older patient in good health? And I think obviously, I think this sort of begs a more general question of how do we approach diagnosis in our patients? When you're in our examining room waiting for us to come in and we're outside the room perusing your chart about to walk in, how do we approach that patient? And what we do in general is we first create what we call a differential diagnosis, which is a list of possibilities, a list of possible causes of pain for that specific patient. And at the beginning, that list is broad. And then we begin the process of evaluating a patient is a process of narrowing the list with the various data points and the various pieces of information we have access to until hopefully we get down to the one single cause of your pain, or at least 1, 2, or 3 causes. We narrow down the potential causes of pain. And we use age and activity level, other health problems, the mechanism of injury, traumatic versus chronic, the type of injury, how bad it hurts, where it hurts, all of these different parts of your history combined with your examination, and then finally the diagnostic imaging all help us narrow down the list of possibilities. So what could cause groin pain in our older patient? Well, probably the number 1 most frequent cause of groin pain is the hip joint, and namely arthritis of the hip joint. Some patients may not realize that when we talk about the hip, we actually think about the groin, because when the hip joint hurts, when the ball and socket joint hurts, it's going to hurt in the groin. So when you describe groin pain, the first thing I think about is the hip joint. And the most common cause of pain in the hip joint in an older patient is probably going to be arthritis. And a common trait of arthritis of the hip joint is that it can actually radiate along the thigh toward the knee. So certainly over Zoom with such a brief amount of information, we don't definitively know what the cause of pain is in your case, but hip arthritis is certainly going to be on the list. When you describe cramping pain, though, it also raises the possibility of muscular pain. So there are various muscles that originate in your groin and radiate along the thigh toward the knee that can also cause pain. So a muscle strain, one of the muscles that originate in the groin area, the adductors, the muscles that bring your leg toward the midline, the groin muscles, or some of the hip flexors, which also can originate in the groin region, can create cramping pain in the groin, even in an older patient. So those would be the 2 most likely causes of pain, arthritis or a muscle strain. There are several others. And again, the history, the examination, and some diagnostic imaging will help us further narrow down the list and develop an appropriate treatment plan. All right, so this next question comes from a post-operative patient. This patient had shoulder surgery a year ago and thankfully has recovered well from this procedure. He has now developed tennis elbow and wondering what options are available for the management of tennis elbow. He describes that he had treatment about 20 years ago, a needle into the elbow, not cortisone, just liquid that stimulated blood flow. A 5-week treatment, worked like a charm, but don't know what it was called. Do you do dry needling? So in essence, treatment of tennis elbow. So first of all, what is tennis elbow? Tennis elbow is a version of tendonitis. It affects the tendons that attach to the outer part of the elbow. Right over here, there's a bony prominence on the outer part of the elbow, and tendons attached to that bump. They then travel down the forearm and become the muscles of your forearm, which travel towards the wrist and fingers, and they are responsible for extending the wrist and fingers and stabilizing the wrist and fingers for grasping things like tennis rackets, for example. That's partly how it got its name. And this condition refers to a degeneration of those tendons. And this condition is extremely painful with any activity that requires grasping or lifting. So rackets and clubs are common culprits, but twisting a jar, shaking a hand, opening a doorknob, using a screwdriver, lifting a bag, any of these conditions can create pain from tennis elbow. The problem with tennis elbow is it takes a very long time to get better. Anybody who has suffered from tennis elbow can attest to this. It can take a minimum of several months, if not longer, to fully recover, and this can be exceedingly frustrating. The other problem is it's really not easy to rest, which is a common treatment recommendation, because you use these muscles every time you grasp and lift, and there's really no way to avoid it. There are many other treatments that have been recommended, and these span from the most intuitive things like anti-inflammatory medication and icing of the affected area for 20 minutes at a time, to home stretching.
Sorry, I'm having trouble.
With the elbow straight, you simply pull the wrist downwards and you feel a pull on the outer part of the elbow. Repeated stretching in this way throughout the day can be helpful. But two of the evidence-based approaches to treatment include, number one, nighttime splinting. Many patients ask us about the bubble or the band that people wear across their forearm. That's a tennis elbow brace or a counterforce brace. Those are commonly used, but they aren't always that helpful, and there's not a ton of evidence to support their use. A wrist splint, on the other hand, is evidence-based. There's a lot of evidence to show that it works, and the theory is that it maintains your wrist in a neutral position during sleep. It's meant to be used at night. Many patients will ask, wait, why am I using a wrist splint for something that hurts at the elbow level? And the reason is because even though the tendons attach here, the tendons act at the wrist level. So maintaining your wrist in a neutral position for sleep allows these tendons to recover. So I recommend that people use a resting wrist splint, which they can get from CVS, for 2 to 3 weeks at night to see if it makes a difference. And if so, they can continue it. The other treatment option that is evidence-based is physical therapy. Patients often don't have time to pursue therapy, and in this pandemic era, some patients are concerned about safety, and rightly so. But if possible, physical therapy can be exceedingly helpful and is proven to work for this condition. But this particular audience member is asking about injection type procedures, and it's a controversial topic when it comes to tennis elbow, and there are various types of things that can be injected. The most common is cortisone, and in previous eras, it was standard to receive a cortisone injection for tennis elbow. The problem is that we have some evidence recently to suggest that injection of cortisone for tennis elbow may or may not provide short-term relief, but seems to increase the chance of having another episode of tennis elbow within a year. So unless the patient is adamant about receiving an injection, I try to discourage injection of cortisone for this, especially just as we're getting started with treatment. Another injection procedure is what this patient may have had 20 years ago, which is injection of some sort of fluid, likely saline or salt water, over a period of 5 weeks, repeatedly in the area, using a needle in the area of these injured tendons. And that's less commonly done in this day and age, but it represents a general category of treatment, which is called needling. And the theory with needling is that you simply repetitively needle the affected area, and it's meant to stimulate blood flow to the injured tendons to theoretically achieve some degree of healing and pain relief. And there is some evidence to show that needling procedures can be effective. We don't typically inject fluid anymore, but some docs will favor needling for this. It's just less commonly done than it used to be. I think that the current version of needling to stimulate blood flow is an injection procedure called platelet-rich plasma. And some audience members may have already heard of this. With platelet-rich plasma, the patient's blood is drawn in the office. The blood is then spun down in a centrifuge, and this allows the doctor to concentrate the platelets in a platelet-rich plasma. The rest of the fluid from the blood is discarded, and this platelet-rich plasma is then injected back in at a site of injury, in this case, the origin of the tendons where they attach to the bone. And theoretically, these platelets are useful because they have very powerful growth factors in them. That's primarily the job of a platelet, is to bring growth factors through the bloodstream to a site of injury so that those blood growth factors can participate in healing. So there's a theoretical intuitive role for platelets. The evidence is equivocal. There's not necessarily overwhelming evidence that PRP can help various conditions, but among all the conditions where PRP is used, perhaps tennis elbow has the strongest evidence. So there may well be a role for PRP in the management of tennis elbow. And that's something that you can discuss with your doctor in further detail. I tend to reserve PRP for those patients who have already tried more conventional treatment options and still struggle with pain, and perhaps surgery is becoming an option, but they'd like to try other conservative tools. So PRP is perhaps the modern day version of what Scott's asking about, and it does have a role. You also did mention dry needling, and that's slightly different. So I mentioned the needling procedure for tennis elbow. Dry needling is something different. Dry needling is a procedure that therapists do in our physical therapy offices. And the way I describe dry needling is it's basically a medicalized anatomical version of acupuncture. It uses the same needles. It just uses them in a slightly different way. It inserts needles directly into the muscle to stimulate whatever muscle is affected by the pain condition, to stimulate contraction, alleviate swelling and inflammation, and perhaps improve pain. And I think there certainly is a role for dry needling in rehabilitation of a pain condition, primarily pain conditions that involve muscles. But I categorize dry needling in the physical therapy bucket of treatment options. And that's something that you can discuss with your doctor or your physical therapist. This is slightly different than the needling procedure that has historically been done for tennis elbow. But I certainly share your frustration with tennis elbow. It can hurt a lot. It can hurt for a long time, and it can come back even when you've been pain-free for so many years. So hang in there, though. Thankfully, the rule is that tennis elbow does tend to get better on its own, and only rarely do we ever have to consider surgery for this condition. Okay. Next question. Let's see. Do you notice that people who have risk factors such as diabetes, smoking, or are overweight have trouble healing or heal slower? What do you suggest, or what is your plan of action with those types of patients? This is a fantastic question, as something we think a lot about as surgeons, because healing is foundational to the work that we do, particularly when we're talking about broken bones and torn ligaments and tendons. In fact, as a shoulder surgeon, as a sports medicine surgeon, most of my work is focused on healing of injured soft tissues, either on its own or after an operation. So we are very much preoccupied with how medical conditions can affect healing. And you're absolutely right that certain medical conditions can negatively impact healing in terms of the pace and also in terms of ultimate healing rates, what the percentage chance is of successful healing. And the two that you've mentioned, diabetes and smoking, have been shown to have a negative impact on healing. I think smoking is much more of a negative prognostic factor. And some patients actually don't realize this. I think we all have talked a lot for decades about the impact of smoking on lung health, and that is certainly true. We've talked a lot about risk of cancer in association with smoking, but as orthopedic surgeons, one of the other things that we're very much concerned about is the impact of smoking on blood flow. For us, in order to achieve healing of bones and healing of soft tissues, we need blood flow. And in order for blood to get to an injured structure, it has to pass through the larger veins and then to the large arteries and then to the smaller arteries, and then to the tiny little blood vessels, the capillaries that provide blood to the tissue. And what smoking does is it decreases blood flow through these capillaries, these microscopic vessels. And it has a profound impact on healing speed and also healing rates. And that's been shown time after time in research. Diabetes also has a similar effect on blood flow, and so too can have a similar effect on healing. I guess the corollary of this is their effect on infection rates. Infection is the albatross of any surgeon, but an orthopedic surgeon in particular, because we're often putting metal and plastic parts in as a part of the work that we do. And when an infection occurs, it can be a big problem. And so we're very concerned about infection, and there has been an association between smoking and infection for sure. The connection between diabetes and infection is a little bit more controversial, but there also has been an association between diabetes and infection in certain types of surgeries that we do. The relationship between obesity and surgical success is more controversial, but I think weight loss can have a profound impact on orthopedic conditions in so many different ways that I think the take-home point is that the more we can do to optimize diabetes, to encourage smoking cessation, and to encourage any amount of weight loss will benefit our patients profoundly. And what I often tell patients, whether we're talking about their hemoglobin A1C or the amount of cigarettes per day or their body mass index or their weight status, is you can't necessarily skip from your current status to your goal. You, just like the exercise we talked about, you have to break your goal up into micro goals. So for weight loss, for example, if you think you need to lose 20 pounds, that's not always helpful or achievable. I often ask patients to just simply think of the first 2 or 5 pounds and achieve that first. That is often achievable. And once you achieve those first 2 or 5 pounds, kudos, you've already made a profound impact on your overall health and orthopedic health. And now let's move to thinking about the next 2 to 5 pounds, and then the next 2 to 5 pounds until you've reached your target. The same thing is true for smoking. Don't go from 2 packs to 0 packs. Just trim down by 2 cigarettes per day. You will have already made a meaningful impact on your health. And then work from there to achieve your ultimate goals. So micro goals can be exceedingly helpful in being successful. Hopefully that's helpful. I think that there are some surgeons out there that have drawn hard and fast lines on what body mass index they will operate on or not operate on, whether they'll operate on a patient who's currently smoking or whether they require cessation. And I think there are not only pragmatic challenges there, it's not always achievable. There's also moral and ethical concerns in terms of access to care. So for me, for example, I think it's right and encouraged to recommend cessation and recommend lifestyle changes, but it may not necessarily be appropriate to require cessation or to require certain lifestyle changes before operating. And that's a much more lengthy conversation that I'm certainly happy to have. But in general, yes, these factors are important and should be addressed with your orthopedic surgeon. Okay, our next question, is it safe to get a cortisone shot when on blood thinners? And I think the short answer is yes. It is safe and it's routine, and we certainly administer injections all of the time. Patients often ask, what are the risks of cortisone injections? And I think the major ones are, all of them are theoretical and exceedingly rare, thankfully. Cortisone injections are routine and safe. I think that the typical risks that we talk about are the theoretical risk of infection, which certainly can occur anytime you're putting a needle in a joint, and the consequences of infection are significant. There's a risk of damage to the tissue. If you administer too many injections into the same spot, then you can have a negative impact on the soft tissues around that joint. So we try to be judicious in terms of when and how many injections we perform. And if you're on blood thinners, then there is a risk of bleeding in the area of the injection. So we try to be as atraumatic as possible. And thankfully, with familiarity of the anatomy, we can usually administer the injection in a relatively atraumatic way so that there is not significant bleeding. Okay, moving on to the next one. I'm in my mid-20s, and I've had chronic pain for years under my shoulder blade, and more recently under the pec muscle. Do you think it could be neck related? It's on my right side. Good question. And this raises a point we try to teach our trainees all of the time, which is anytime we evaluate the shoulder in a patient, particularly when it's diffuse pain that doesn't correspond to a single anatomical area, like where the rotator cuff would hurt or the biceps should hurt, in this case, in and around the shoulder blade, we always have to consider the cervical spine. There's a ton of crossover between the neck and the shoulder. So I often evaluate shoulder patients and refer them to my partners who specialize in necks, and vice versa. They often start with a patient who presents with neck pain, and they end up sending the patient to me for further evaluation of the shoulder, because these two conditions and these two anatomical areas often overlap. Patients with a neck problem may not even have neck pain, but if the right nerve is being pinched from a bone spur or from a bulging or herniated disc, then that pain can radiate to a different area, and sometimes it can radiate to the area of the shoulder blade. So we can chase our tail evaluating the structures that surround the shoulder blade, but the pain is actually originating upstream. So we will often include the neck in our evaluation, first with x-rays, and then sometimes with an MRI. But there are conditions that can affect the shoulder blade itself. Thankfully, they're usually not structural conditions. In other words, they're not usually tears that are going to require surgical treatment, for example. They usually are overuse conditions of the muscle or inflammatory conditions of the tissue between the muscles. The shoulder blade is a thin wafer of bone, and it's wrapped in a ton of different muscles. There are a number of muscles that either originate or attach onto the shoulder blade, and any of these muscles can be strained. And the layers in between each group of muscles have tissue called bursa there. You might have heard of bursa because we have them all over our bodies. Bursa are deflated, slimy sacs of tissue that serve to lubricate one structure from another. Anytime we need structures to glide back and forth against one another, the body has placed a slimy bursa there to serve as a lubricant. So in the back of our shoulder blades, in between each group of muscles, we have bursa that can become inflamed and can also be a source of shoulder blade pain. So there are both focal conditions that affect the shoulder blade, and there are also referred conditions of the neck that can. So looking at the neck is a very good idea. Okay, the next question, what is the difference between aggravating a nerve, like the ulnar or radial, and aggravating a muscle, like the biceps or triceps? Do you alternate between ice and heat? Good question. And I think those are really two completely different groups of conditions that present in different ways. So aggravating a biceps or a triceps can either be aggravating the muscle, which is essentially a strain, or aggravating the tendon of the biceps or triceps, which can be a tendinitis, which can affect the end of the muscle where it attaches to the bone. Nerve conditions, on the other hand, are often either compression or stretching of a nerve. And these can occur anywhere a nerve travels through a narrow space. So everybody's heard of carpal tunnel syndrome, where the median nerve gets compressed in its tunnel as it passes through the wrist. And it's called the carpal tunnel. And the median nerve gets compressed there. And when a nerve is either compressed or stretched, it typically creates nerve type symptoms. And those include primarily numbness and tingling. So in the case of the median nerve, carpal tunnel syndrome, it's these three fingers typically. Or it can be a burning pain, or it can be an electric type symptom, like when a kid used to put their tongue on a 9-volt battery, for example. That sort of burning zinger type pain can be reflective of a nerve type pain. So the type of pain you experience and the location of the symptoms differ if it's a muscle tendon unit versus a nerve. If a nerve is being stretched or compressed, it won't necessarily hurt where it's being stretched or compressed. It's going to hurt where that nerve goes to provide skin sensation, or in a more severe case, it'll create muscle weakness of the muscles that are supplied by that nerve. So we're usually able to hone in on either muscle tendon conditions or nerve conditions based on the type of pain and the location of symptoms, and the presence or absence of weakness. And then you asked about ice or heat, which is a good one. I think that's a good general one we get asked about a lot. And the general idea with ice and heat is there really is no evidence to support either one. And the New York Times has even written interesting articles on their health blog about why ice might be a good or bad idea, and so on and so forth. I've created rules for myself and my patients that are sort of simple to live by and are intuitive and they're anecdotal. So they're, again, not necessarily evidence-based, and the evidence is all over the map. But in general, ice is better for inflammation, and heat is better for muscle spasm or strain. Ice decreases inflammation, heat improves blood flow. So with those general rules, what I typically encourage my patients to do is use ice after an episode of exertion, either after PT, after exercise, after a long day of work. 20 minutes of ice. You don't want to do any more than 20 minutes because you can burn the skin. And you can ice as many times as you want. There's dogma that ice is only helpful right after an injury. And that's true, it is, but it's not only helpful right after an injury. It can be helpful even in the absence of injury. Our high-level athletes use ice even without any injury at all, just after their training sessions. When I travel with the rugby team, if we're in Atlanta, for example, where they often train, we'll get in ice baths after a hard training session, even in the absence of injury. And we use it as an anti-inflammatory tool. And you can use it in the same way. Heat, on the other hand, I tell patients to use heat the last thing they do before they go to bed and the first thing they do before they wake up. And these general rules, ice after exertion, heat at night and in the morning, is just an extrapolation of how our therapists use ice and heat. If you've been to therapy, you might have noticed that when you show up, they start off with some moist heat on the affected extremity to loosen things up and get things going. And then they'll do some they'll do some ice afterwards to cool it down. And that's just how I extrapolate ice and heat to be used throughout the day. All right. How long does it take to get better from a knee replacement? I still have some pain after 10 weeks. So in the interest of full disclosure, I'm a shoulder and elbow surgeon and a sports medicine surgeon. I operate a ton on the knee, but I leave the replacements to my partners. So I'll give you my take, and then they can maybe provide some color and flavor to it. But the general rule with shoulder replacements, which it can be similar to knee replacements, is that at 10 weeks, you are still in the heat of recovery. You should certainly expect to have some discomfort at 10 weeks. That's not unusual. What I tell my shoulder replacement patients is that, at 6 weeks, they're going to be feeling so-so. At 3 months, they're going to be feeling pretty good. At 6 months, they're going to be basically 90% through their recovery and be feeling great. They're still going to have 10% of their recovery left from month 6 to month 12. They won't know it. They'll be living a normal life. They'll be benefiting from their replacement and feeling good, but they'll still be doing some sort of exercise on their own, and they'll have some incremental improvements from month 6 to month 12. But at 10 weeks, some discomfort is certainly appropriate, particularly activity-related discomfort with your therapy, because you'll be working hard still on regaining your movement. And some end of the day or nighttime discomfort is also certainly to be expected, which is sort of cumulative throughout the day. And also now with no distractions, people tend to notice pain at night more. That is certainly not a red flag. So I assume coming up on 12 weeks, you'll be seeing your surgeon pretty soon, and you can get some reassurance from them as well. But a little bit of discomfort at 10 weeks is nothing to be concerned about. Are there certain injections that you prefer to use over another when it comes to reducing pain in the knee? And I assume you're talking about cortisone, which we've talked a little bit about already, hyaluronic acid, which is also referred to as gel, or PRP. And it's a great discussion with no definitive answers, but what I often group cortisone and gel together. They have similar levels of evidence, and when they're compared head to head, they tend to show similar results. Cortisone is a bit pragmatically simpler to administer. It's a single injection that can be given right in the office. Gel is given typically as a series of 3 injections spaced 1 week apart, and oftentimes requires insurance pre-approval. So for pragmatic reasons, we usually start with cortisone and we see how much benefit we can glean. If a patient doesn't benefit from cortisone, then the gel can be considered. with an understanding that its effectiveness and duration of effectiveness can also be unpredictable. PRP is sort of in its own category. We've also talked about PRP as it pertains to tennis elbow. It's the same treatment. We draw the blood, spin it in a centrifuge, isolate the platelet-rich plasma, and then inject the platelet-rich plasma, in this case, in the knee. There is some recent evidence to suggest it may have a role in arthritis. Its mechanism is unclear, but it's also thought to be an anti-inflammatory action. It doesn't regrow cartilage in any way. It doesn't reverse the arthritis in any way. It's simply used as a pain management tool. The downside of PRP is that it isn't covered by insurance. And so it is going to be a financial commitment for the patient. As long as they've tried other more traditional options first and they've been informed about the likelihood of success, then it can be a reasonable option for some patients. The good news about PRP and gel is that they're both safe. There's minimal downside other than the intervention itself and the theoretical risk of infection. There are plenty of other injections that can be given. There's stem cells and amniotic fluid, and the list goes on and on. I usually describe it to my patients as increasing levels of cost and financial commitment and decreasing levels of evidence. And you can sort of work through that algorithm with your surgeon to kind of have a more thorough conversation about likelihood of success in your particular case. I would just say that steroid and gel are the more traditional treatments that admittedly have variable response. PRP is catching on, but also has unpredictable response and isn't covered by insurance. And I usually sort of consider those three options and reserve stem cells and amniotic fluid because just the data isn't strong enough yet. I have a pain in my shoulder since March. It hurts a lot when I go to bed at night. I also can't make some movements without pain. Do I need an appointment or will it go away? So great question, both pragmatic and what do I have type of question. And I think thankfully, most of the conditions that we treat in the shoulder will get better on their own and won't require surgery, just as a general rule. So it's never a bad idea, especially in the absence of a specific injury or a traumatic event, to try to manage it on your own if you can. I think just waiting for it to get better may not work, but if you institute a program of rest from strenuous exercise for at least a couple weeks, if not longer, some periodic icing to the shoulder, particularly after exertion, an anti-inflammatory medicine like Aleve, Advil, or ibuprofen, if you're able to take those medicines. See if that program works on its own for a few weeks. If it starts to work, you can continue that program and see how much improvement you experience. If it doesn't work, then I do think it's time to see a physician. I think the one red flag that might prompt an evaluation by a physician sooner is night pain. Night pain is often a symptom that can predict something more significant than just run-of-the-mill tendinitis. So start with your own simple program and then have a low threshold to see a doc, primarily because of the presence of night pain. It still is true, though, that when you go see the doc, they are likely going to diagnose you with something that will get better. They may just add some other treatment modalities, including physical therapy, maybe an injection of steroid, but they'll want to examine you, take a detailed history, get an x-ray, and they might consider an MRI if there are other associated symptoms or signs like weakness of your rotator cuff. Okay, we got a couple others. This is some more flavor on your question. I apologize. It's getting worse with time. I was playing volleyball, and I think that caused it. I tried ibuprofen. So hopefully, you know, what the advice I've given is helpful, even with those details in mind. I guess Spencer's asking about Epat, and maybe if you can provide some additional details, I might be able to give you some additional information on that. While Spencer might be typing in, maybe I'll just take a step back to Victoria's question about do I need an appointment? I think when patients come to see us with shoulder problems, one of the questions we commonly are asked is, do I need an x-ray? what is an x-ray going to show? Isn't it my rotator cuff? And doesn't that not show up on x-ray? Don't I just need an MRI? And I think my discussion of x-ray and MRI is that they are the third pedestal in the evaluation of a patient. There's the history, there's the examination, and then there's the imaging. And I don't view x-rays and MRI as either or. I view x-rays and MRI as also and. They're complementary tests. We sort of need to take the initial step of doing this easy, safe, quick screening test, the x-ray, to look at bony conditions that can create pain and indirect evidence of soft tissue conditions that can create pain. Some people have arthritis and actually don't even know it. They've been living a great life with arthritis, and then all of a sudden, for whatever reason, it becomes painful. And that needs to be seen at the outset of treatment so that we don't go down the wrong road. There's indirect evidence of soft tissue concerns. We can sometimes see calcium deposits within the rotator cuff, a condition called calcific tendinitis. That can be an exceedingly painful condition that shows up on x-ray. We can see large bone spurs on x-ray that can pinch on the rotator cuff with a condition called impingement, which can lead to bursitis or tearing of the rotator cuff. So those spurs can be recognized on x-ray. And alignment issues can also be seen on x-ray. So there's a long list of clues that we can pick up on x-ray to identify both bony conditions and soft tissue conditions that can lead the way with initial treatment of a painful shoulder. And we really reserve MRIs for when we have a high index of suspicion of not just a soft tissue condition, but a significant soft tissue condition. Because bursitis and tendinitis and other similar pain conditions, frozen shoulder is another example, these conditions tend to get better with conservative care, and MRIs aren't really required. The times we typically get MRIs are twofold. One is if we see a red flag on our initial evaluation. If we pick something up on the history, or if we find something on an examination that raises our concern for a significant problem, like a full thickness tear of the rotator cuff. If we pick up one of those red flags, then we're likely going to recommend an MRI rather early in the process of evaluating the patient. If not, then we'll usually take the first steps of conservative care and reserve an MRI for later. The other time that we'll get an MRI is if the patient has already tried conservative management. If they've given it 6 weeks of therapy, anti-inflammatory medication, or other structured management, and it hasn't gotten better, that's another patient where we're likely going to recommend an MRI. But an MRI is not at all necessary for any patient with shoulder pain when the concern is the soft tissue, because we can usually get enough information to take the first steps in management with history, physical examination, and x-ray alone. Okay, so let's move on. We have some other questions. So I see Victoria asked, isn't an MRI more accurate? Hopefully I've answered that question with the most recent conversation. Karen asks, I have a burning, stinging pain in my knee. I'm in my 60s. I may have taken a step slightly off to trigger the pain, but it was nothing too significant, so atraumatic in nature. It's been 2 months, the pain hasn't improved. It's not always present, but it's very painful when my leg is in certain positions. The knee was operated on 40 years ago to repair a torn meniscus. I have arthritis in my hips and back. So a lot of very, very helpful information there. Karen, thankfully, is a very detailed historian and has given us a lot of information we need to start to hone in on what the cause of pain might be. And similar to the discussion of shoulders, there is a long list of causes of knee pain, both bony and soft tissue, that are on our initial differential diagnosis, as I've mentioned. We start to take some of these clues and we start to narrow down the list. I think the location of pain can be exceedingly important in determining whether this might be soft tissue or bony in nature. What's important about Karen's history is that she had surgery a long time ago for a meniscus. So when we hear that, then a recurrent or persistent meniscal tear or arthritis in somebody who had an old meniscal tear starts to crop up to be higher and higher on the list. And if her pain is in the right spot, meaning either on the inside or on the outside part of the knee, we're going to be even more interested in the meniscus. I think just to take a step back a little bit, this is the knee joint here. I'm going to peel away the patella and the patellar tendon. And now we're looking at the inside part of the knee. And what you see here are these rubbery structures that sit in between the knee, which are the meniscus, these two structures here. There's one on the outer part of the knee. There's one on the inner part of the knee. And it truly is a rubbery structure. It's a wedge-shaped C or ring of tissue that sits in between the bones. And it serves as a shock absorber between the tibia and the femur. And these meniscus can commonly be torn even with everyday life. It doesn't require trauma or sports or working on a construction site. Daily grind, daily impact is enough. Meniscal tears are exceedingly common. Just having a meniscal tear isn't necessarily a problem, but having a painful tear is. And if the pain doesn't go away, despite conservative management, then some people will have surgery for their meniscus. Now, Karen mentions a repair of a torn meniscus. The truth is, only a small minority of meniscal tears are treated with repair. And even when patients may describe a surgery as a repair of a torn meniscus, most commonly we're talking about a meniscectomy or a partial meniscectomy, where we clean or remove the torn fragment and we leave the healthy meniscus behind. Only in our youngest patient with a discrete acute tear in the right spot where there's good blood flow is the meniscus repaired, and that's a very small minority of the meniscal surgeries that we perform. Usually we're trimming away the torn meniscus, and as long as we don't trim away too much of it, as long as it's only a small portion of the meniscus that's affected, there's no significant increase in risk of arthritis. But in patients who had a very bad meniscal tear, where a moderate amount of the meniscus or a large portion of the meniscus was affected by that original tear and therefore had to be removed, that patient may be at slightly increased risk of arthritis. So in this patient who has a history of meniscal surgery many years ago, we definitely are going to want that X-ray to evaluate for the possible presence of arthritis. But if the X-rays show that there is no arthritis, then we may be simply looking at a minor recurrent tear, or in the simplest case, just a tendonitis. There are several tendons that cross the knee, both on the outer part, namely the IT band, or on the inner part, namely some of the hamstrings, or in the back part of the knee, the posterior portion of the knee, either the calf muscles or some of the other hamstrings that can also create pain. So in the simplest case, Karen, it may be a simple case of tendonitis, but we would want to evaluate you to determine whether or not there's some early arthritis brewing, or whether there may be a mild recurrent meniscal tear that can be managed conservatively. All right, so Spencer provided some clarification talking about extracorporeal shockwave therapy. So yes, is extracorporeal shockwave therapy effective? And it really depends on what condition you're talking about. And it really is, again, technician dependent in terms of how that extracorporeal shockwave therapy is administered. There are some conditions where it is more commonly used, and one of those conditions is plantar fasciitis, for example. It has also been used in tennis elbow. And I think what you see there is it's used for conditions that have a reputation for being very stubborn. So we tend to open up the kitchen sink and try anything at our disposal to help these patients, because sometimes the more traditional treatment options don't work well. So I would just say extracorporeal shockwave therapy is in the category of things that can be tried for some of these more stubborn conditions, but the evidence to support its use is varied. Okay. So some additional information from one of our audience members about their painful shoulder. They've been told they have a torn rotator cuff. Do they need surgery? And I think this is a great way to maybe finish up our session, particularly as a shoulder surgeon. I am always excited to talk about the rotator cuff. It's an incredibly common source of pain. Even just the inflamed rotator cuff can be painful, but sometimes shoulder pain is caused by a tear. And there are essentially two types of tears. There's partial tears where the tendon is still attached but might be frayed. And there's complete tears where at least a portion of the tendon has completely pulled off of the bone. And treatment varies depending on the extent of the tear. Partial tears do not need surgery. They're still attached, the cuff is still able to do its job, and it has a very low risk of progression. to a full tear, and then to a bigger full tear. So partial tears can absolutely be managed conservatively with some combination of rest, icing, medication, sometimes an injection, and patients will typically get better. Only the partial tear that continues to be painful and is high grade in nature, meaning a majority of the tendon thickness is involved, would we consider an operation. Full tears are a different discussion, still controversial, and depends a lot on the various parameters of the patient: age, activity level, health status, and other health conditions, your recreational activities, your job, what you like to do for fun. All these things will factor into decision making, and then the status of the full tear itself. How big is the full tear? Is it acute? Did it just happen yesterday? Is it chronic? Has it been there for 5 years? What is the health of the muscle attached to the torn tendon? Is the muscle very healthy and lean, or has the muscle already begun to undergo chronic change where it atrophies and becomes marbleized with fat? All these things factor into how we treat full tears. In general, for our younger active patients with full tears, we are talking about fixing it because full tears don't heal. Full tears will persist, and full tears may enlarge over time. So when we're deciding on treatment for a given patient's tear, we're basically either accepting the tear and managing it or operating on it in order to get it to heal. So for younger active patients, repair is often the treatment of choice. For our older patients or our less active patients with smaller tears, we can certainly begin with a conservative course. And many of those patients will feel better. The rotator cuff is a confusing structure because tears can happen on their own. They don't require trauma. Not all tears need to be fixed. Some tears will become painless. And so the rotator cuff tends to violate a lot of the intuitive rules that we think about with orthopedic conditions. So there definitely is a role for conservative management. We definitely tend to reserve it for specific patients. There's a third group of patients that have a tear they just didn't know about that has existed for a long, long time. And by the time they get to see a doctor, it's already a chronic, irreparable situation. It's either pulled away too far, the tear has become too large, the attached muscle has undergone too much chronic fatty change, or the patient has already developed arthritis in association with their tear. Those patients are always managed conservatively, and we reserve a different type of operation for them, but repair is not always in the cards. So hopefully that's helpful. The cuff tear management is very complicated and really depends on the specific patient. So I think if you know you have a cuff tear, I think it does make sense to sit down with a shoulder surgeon and talk about your treatment options. Got it. Well, it seems like we're winding down and we're coming up on an hour. So I just want to thank everyone for taking time. I think, honestly, this medium is so much more enjoyable than giving an hour-long lecture. It's so much more relevant to your situation. It's so much more dynamic, and we can really have lots of different conversations about what ails you. So I hope you enjoyed it. I think Cindy has arranged for us to do a lot more of these, and you'll see some other faces from the practice across all specialties. This talk was recorded and will be posted within a couple days. And if there are specific topics you'd like to discuss, either in this fashion or with a more structured lecture, please let us know by emailing contact@ONSMD. So again, thank you very much. And everyone, please stay safe. And I hope you enjoy your holiday. Take care.